So we're now going to move on to our next session, where we are picking up where we just left there, which is the evidence is there, we need our values, we need the energy, the determination, and now we're going to talk about how to go from evidence to advocacy to policy change, because we call ourselves agents of change, we're in the business of change, and we're now going to talk about it. And leading us through it, Charlotte is going to take that role. I hand you the baton of moderation. Charlotte, the floor is yours.
Sorry, me again. I stepped in on the previous table. I think you would have loved to hear from environment people, but this is what we will have. Please, the people from our panel, if you would like to join while I'm just sharing the introduction. So we talked all the morning about all what we need, and we need advocacy for policy change. So, but how do we know we have impact? How do we know that we are actually reaching it? So we'd like to show how it works and have examples and show the different dimension and the opportunities to advance, so that we keep optimistic and that we keep empowered for the next step. So some decisions, some difference are the geographic coverage. We talked about national and local, but we also have region, we also have opportunities, and region like the Mediterranean or the Northern Europe, which have different ways of addressing health, and we've seen that. So the second dimension is the approach to the policymaker. How do you approach them? If you're not running, if you're not in office yourself, how do you get the deal? So I'll have 3 questions. Again, it's 3 minutes. Thank you so much for joining. To leave you more time to speak, I'll let the people see who you are and just see how many things you've done, because if I do your bio, we'll have for a lot of time. But I'd like to begin to ask you, Nick, from the perspective of seeking change at European level, and what would be the most important things you lesson you learned about tips and strategy necessary to get this evidence that we have on the policy decision maker and translate it to decision?
So I'm a liver doctor. Most people die of liver disease because they drink too much alcohol. They die at a young age. It's the second leading cause of death in working age after ischemic heart disease. And I think the first thing is you have to understand the structure of what you're dealing with. And alcohol and liver disease are slightly different, because most, alcohol causes cancer, it causes high blood pressure, and it causes liver disease. Cancer and all the other problems, there's a linear relationship. If you drink more, you get more cancer. It's a straight line. Liver disease is completely different. It's an exponential relationship. So the more you drink, the much higher the risk. The relative risks are 40 or 60 times for really heavy drinkers. That makes a difference, because it means that instead of a population of a large number of people drinking a little bit too much, my wards are full of people on average drinking 4 bottles of vodka a week. A small number of people at very high risk. If you look at trajectories of liver disease in populations, in France in the 1960s, the liver mortality was 50, in the UK it was 2. We overtook France in the 1990s. You have massive variations because you have small numbers of people drinking a huge amount. Becoming dependent on alcohol it tends to be a binary phenomenon. You switch from drinking to not drinking. You don't just drink a bit. They're like virtual quantum particles flicking in and out of existence. Behavior change is extremely possible as a result of those structures. You have to convince your colleagues and your patients to support you, because if you're going to sit with a minister and you've got a patient beside you, that's a completely different scenario from sitting there as a lobbyist. Doctors aren't taught about public health. Patients don't like to talk about alcoholic liver disease because of the stigma associated with alcohol and the stigma associated with liver disease. So it's difficult to recruit your supporters, but they're absolutely vital. The nature of alcoholic liver disease defines the solution. The solution to alcoholic liver disease is price, 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 price. And then for children, it's marketing. It's an industrial disease like tobacco and asbestosis. Okay, these are commercially mediated diseases. You have to campaign on price in year 1 and year 2. You can't say, oh, we're bored of doing minimum unit price. Can't we do something else? No, you have to find a different way to tell the story. If you work for Heinz, you can't say, oh, we're bored with doing baked beans. Can't we do something else? Okay, you have to, you have to stick to the script. And then I'll stop at this. Just say one thing. Sometimes you get very small windows of opportunity. I got a phone call late one night from Sarah Wollaston MP. She said, I've got a meeting with the Prime Minister tomorrow morning to talk about alcohol. What shall I say? So I wrote her a 1-page briefing document. She had a meeting with David Cameron. The result was that David Cameron came out in favour of minimum unit price. And actually, it's still the official government policy. Unfortunately, the right wing got to him, fueled by the drinks industry, and the decision was reversed. But that was a tiny virtual quantum window of opportunity, which opened and closed almost immediately.
Thank you so much. Yes, always be ready for windows of opportunity with good policy briefing. Sheila, you won cases. You have huge experience on alcohol. Can you tell us how you won? How is Europe important to that? And how can we extend this alcohol victory to other health issues?
Sure. So just as a quick recap, because not everybody might know of our win that we have. So alcohol products, unique among consumables in Europe, have no labeling. There's no standard thing that says, here's the ingredients, here's warnings, here's anything else, in the way that you do for just about any other product. Even a bottle of water tells you exactly what's in it. But alcohol, in its exceptionalism as an industry, managed to get a derogation from this. So that's a European situation. So in Ireland, as part of a larger package of measures, which included things like pricing, which is really the most important, without a doubt, I would get that, and also some restrictions on advertising. And I'll just jump in and say it is very important to have restrictions on advertising, because apart from that, it is a driver for use. If you strip out the marketing myths, it actually makes it easier to get the pricing kind of things that's there. So that's just a quick aside. But back to our story, we have in Ireland, as part of that package of measures, a proposal, which is now in place, to have labelling of alcohol products, which would have health messaging. So a warning about alcohol and liver disease, a warning about alcohol and cancer, which is absolutely groundbreaking, and a warning about drinking and pregnancy, along with a few other bits and pieces like calorie content and things like that. So how did we get there? Given that it wasn't a European-wide thing, we had to both work with Europe and also work as a national competency. So health is a national competency. We can do it. We have the power. Ireland, as a member state, has the power to take control of our actions around health. And what the government were able to demonstrate was that there was a need, there was a reason to have such labelling, and that these labels were proportionate to the scale of the problem that we had. From our point of view, from an alcohol action point of view, what we were involved in was firstly putting forward the evidence. The evidence is incredibly important, and I really appreciate that. Tell the truth, and thank God the truth is easy, because you don't have to lie, you don't have to spin, because the truth is absolutely in our favor in this particular way. But you need all those reports, you need all the different things that actually give you there. But also another piece of evidence that's needed is the popularity of such a move. A very important thing for us was polling data, which showed that 70% of the population were absolutely in favour of it. Most people were actually surprised that we didn't have it in the first place. They sort of assumed that there was something there, but there wasn't. So that kind of evidence is actually something that is important from a political point of view, that's there. So we certainly had a win. We had to work with Europe. We had to say to Europe, look, this is what we're doing. This is what we want to do. But Europe couldn't actually stop us from doing it. And that was also a very important thing for people to realise and to understand that was the case. Now, having got this, we hope that will inspire other countries. We know that Norway, for example, are interested in doing cancer warnings as well. And there is a movement across the EU to introduce labelling. And we would be saying, well, you've now got an example. Here's something you can do. Here's something we can follow. So that's our positive kind of national story. But the reverse is also true too, that when you have a European-wide thing, that can determine how things happen locally too. So we're bathing here in our glory of, we've got labels, we're so great in Ireland, aren't we wonderful? But actually, we've lots of other things that we're not so wonderful about. And some of that is actually just down to some basics about even gathering data. If we were having a discussion about this last night, Ireland doesn't collect data systematically about alcohol, even just something as basic as alcohol deaths. Quite shocking. The last year for which alcohol deaths were published was 2017. I find that absolutely incredible, truly incredible. But if you look at drug deaths, these are actually published every year. And one of the reasons that they are published every year is that Europe, through the EMCDDA, actually the agency which gathers information on drugs, requires its individual member states to produce the data on deaths, on drug deaths. So we get them. I would just love if Europe would ask, can we have the alcohol deaths as well? And that would make a difference. That would be a small step which would actually force a member country to gather the data, which would be helpful, which would help our advocacy about that. So there's two sides to it. There's in that European context, there's how a nation, a member state can change or push towards Europe taking action, and there's the reverse as well.
Thank you so much. Learned so much. Thank you. Freek, I said people were saying I'm not funny, but I've heard you describe that the fox of lobbying and Mr. Unpopular, and that you don't care if nobody likes us. How would you say that you've been moving policies and pushing the lobbying, and how can you inspire us so that we can do it together in collective lobbying?
Well, first of all, thank you for the compliments. I didn't know that I was known as these names.
You didn't know? Okay.
Well,
this is.
There's rumors, yeah, but
I've
never heard somebody saying it to me directly. But I think I'll put it on my business cards.
Yeah, that sounds great.
I'm not a health professional, so I talk with modesty. I work on homelessness as an issue. It's also a health issue. And it's an undeserving cause. I don't have to explain that to you. It's very difficult to get a positive vibe around homelessness. And that's why evidence for us is more than fundamental. It's actually a survival strategy. We cannot exist as an organization on the basis of the number of people we represent or their electoral power. It's the evidence that we can bring together that makes us strong. So let that be clear. We're convinced, because I hear that people try to say, well, evidence, I'm not so sure. Well, for us, it's absolutely fundamental, even if it's not easy to work with it. And what we did to illustrate how important it is, we created years ago, more than 20 years ago, in our European NGO structure, a research network, an academic network. And it's the NGO that decides what the academics are working on. And it's the promise of the NGOs that the results of the research will be published even if they go against the interests of some of our members. And I don't have to tell you that that has caused huge conflicts and problems, etc. But it has made FEANTSA evolve into an evidence-based learning network. And that has been the reason for our survival. And I think we're actually one of the, maybe even the only European NGO that has a research network inside its NGO structure. That's the way we organize it. In the question, there was also like, because you work on an undeserving cause, you have to do everything that is possible. Yes, almost everything that is possible, I guess. But that also includes questioning your own truth. I think that's really important. I see a lot in social NGOs that we're convinced about our truth, but we have not tested if the evidence is as solid as it was 20 years ago. Evidence also evolves. Research evolves. There's new insights, and we have to incorporate them. And I think as NGOs, we also have to admit, maybe not publicly, but at least internally, that we defend to some extent corporate interests, even in the social sector. Our members, most of them, are shelter providers. They want more beds and more money for the beds. And we don't want to promote that as FEANTSA. So we have to try to be modest about our own truth. That's the first thing when you ask, you have to do everything. The second thing is that we have to try to pitch ourselves as co-implementers for policymakers. To say we just, like shouting from the sideline is easy. Asking others to do is easy. But proposing practical things and taking responsibility to implement them together with policymakers, that's another thing. And so I think FEANTSA tries to do that, and our membership tries to do that. And that forces you to put the evidence into practice. And then the third thing that I would like to mention, if you decide you have to do everything what is possible, and it has not been mentioned so much here, it's human rights, or not just human, but litigation. It's easy, like so many people that shout about human rights or say human rights are so important. We have heard it here as well, like human rights are the nec plus ultra of any policy intervention, but so few NGOs litigate. We do it as FEANTSA, and it really is worthwhile. It's difficult, but it's worthwhile. And what might be surprising for you is that if you take on a country, like we have done at the level of the Council of Europe with the collective complaints mechanism, we won, for instance, our first collective complaint against France, you're surprised that you get support from inside the government. Because also inside the government, there is struggles to get more attention, more money to certain causes rather than other causes. So I think my advice is there's plenty of litigation possibilities at national, but also at European level. Also the infringement procedures, for instance, are almost not used by NGOs. I think we should do that. And I'm ready to help for that inside EPHA.
Thank you so much. We see that in climate action a lot, and actually in public health, we're not doing that so much. So that could be really inspiring for a call to action at the end. We see it takes courage, it takes bravery, it takes something to face the lobby and do something different. And that's what you did in London. And the Mayor of London decided to cut emission and do a ultra low emission zone, which came back with some political storm. Would you like to tell us about how it happened and how it's going so that we can be inspired by this political courage and eventually support and spread it out?
Thank you. Yeah, so Vicky Hobart, I'm Director of Public Health for the GLA Group, which includes the Mayor and the Assembly, Transport for London, Police and Crime, Fire, and some of the development corporations. So this is quite a new model of a unit that I'm leading and setting up at the moment. So just to say, from a kind of professional perspective, we're learning also how we work and how we implement. So ultra low emission zone relates to air quality and health impacts. And the events earlier this year were an extension to an existing scheme, which first of all covered central London and then inner London and now the whole of London. I can come back in a bit to talk about some of the kind of how the GLA is set up and health and policies, but just really wanted to share 5 reflections around this process from a public health perspective. The first is around the evidence base. So we need evidence to be reliable, generalizable, and valid. The decision maker needs that to be triangulated. It is difficult as a decision maker to hear evidence and accept it from a single source. Yeah, so decision makers need that to be triangulated. In this case, the evidence around air quality and health has been building for many years in London. Different parts of the system had taken action. This was a policy that had been developing from a congestion focus through to an air quality focus, and will go beyond these measures in planning for a global city. But that evidence needs to be triangulated. 2 of our chief medical officers had focused their entire annual report. Chris Whitty actually did that last year, a national report on air quality. That was important. We held a summit with a range of kind of health leaders in the broadest sense, so including the health system, including community and advocacy groups, etc. So that triangulation of the key messages and the decision makers being confident in that is important. Civil society also plays a huge role in that. Second observation is then supplementing that with stories. So it's fine to have the technical evidence base, to have stress tested that, impact assessment, looking at options, all of that. But how is the decision maker, the politician, going to translate that? So those stories are important. In terms of this policy intervention, we had the very, very sad case of Ella Kissy-Deborah, who had died in South London, whose daughter's death was subject to a coroner's investigation and the production of a prevention of future deaths report. And her mum, Rosamond, was very, very active and continues to be in this space. But also the Mayor of London's own personal story about training for a marathon and developing asthma in the process. So pummeling the streets, running through London, adult onset asthma. And so that translation into stories as a persuasion technique. Third point I get is around the political capital to make these decisions, and decision makers capital, political capital, The London has a particular kind of political setup between the directly elected mayor, strong executive function, and 33 local authorities. Political capital can be spread very, very thin. So it is not that there aren't a multitude of health issues, and that's what my unit deals with. We're arranged in 5 portfolios of work, but you need to be able to spot the political capital stresses and strains as well as other capacity requirements. And that is in a broad sense and applies to all of your corporate colleagues that run the comms team, that run the stakeholder engagement team, digital team, putting up information, and recognizing that for London, the mayor's role, the Greater London Authority, the mayor provides sort of direction to the transport system through Transport for London. And they will have their own version of kind of capital that they're trading within the transport system, not least coming out of COVID, funding challenges, etc. Fourth, I guess, reflection is around how hard it is to influence the narrative. So many people have said to me, they didn't hear the health message coming through. This became, in the moments when the build up to the decision, there was a judicial review of that decision. There was then the mayor's decision. What is reported is not about the health impacts, the intention of the policy around health impacts, particularly on children, impacts on demand for the health and social care system. It is incredibly difficult to get that narrative to cut through in the thrust of the moment. So the really good planning around communications and engagement, never underestimate that. And how are you going to cut through with what you're trying to achieve, whether that be childhood obesity or, we can talk about other examples. And the last would be around the just transition. So what, planning from the outset, what does this mean about health inequalities? If this is about equity, social justice, planetary health, planning that into the policy development. And sometimes, you need to be a bit fluid with the language around that because different sectors approach that still slightly differently. In London, we have the benefit of a health inequalities strategy. The mayor has to provide that, produce that with partners. So your point to what's the direction of travel around health, working back a golden thread, you have to create that in the place where you're trying to get this policy through. Why not other areas, other cities have done this in London. So yes, this gained a lot of attention. Bristol's been doing great work, lots of cities in lots and lots of different ways. There is a legislative framework for this that's set EU, now in the UK context through the government, directives from government, etc. How individual administrative jurisdictions interact with that and their own local politics is nuanced. So you can't just lift what happened in London and apply that to Manchester. The Mayor of Manchester has a different set of powers, responsibilities to the Mayor of London and has different relationship with the local authorities in Manchester. They're in a combined authority, whereas in London, so those nuances. So getting officers and public health colleagues to understand that political context in which you're operating, rapidly accelerating learning around that is really important. We have a project that we're working on at the moment with the M11, so with the other combined authorities to share that kind of learning because the journey is not going to be the same.
Thank you so much. So we've seen that we need several things to translate the evidence to policy making. Let's see, how effective are we? So let's see, we're not, 33%, I think we are very effective, and 66, sorry. Oh no, it's changing. Well, let's see how you think we can do that. You all talked a lot also about the narrative and the story and the need for patients and people to go there. It's again about communication. How would you say we can better communicate and advocate, and how can we frame our speech and evidence?
Yeah, I mean, the evidence is absolutely vital, and you're absolutely right. We've got to tell the truth all the time, and people don't always tell the truth. I'm a visual person. If I had a meeting with a minister, say, I would take a bunch of illustrations on card, not paper, so they're sort of easier to give to people. So you probably can't see that. All you need to know is there's a bunch of coloured lines at the bottom, and that's mortality rates from every disease you care to think of. And this is the same graph, and that's liver mortality, okay? That's the sort of thing that he can give to his advisor and say, well, what do you think about that? You can I came out of a meeting of the Alcohol and Health Forum, which I used to really enjoy battling with the drinks industry, I must say. They absolutely hate any comparison with the tobacco industry. They hate it. They absolutely hate it. And I came out of one meeting and I just thought to myself, I wonder how many cigarettes there are in a bottle of wine as far as cancer risk is concerned. So I went home and I did the calculations and I didn't believe them. And I actually spent several years trying to prove that I was wrong. But the answer, if you're a man, is 5 cigarettes in a bottle of wine. If you're a woman, it's 10 because of breast cancer. Now, we published that in a peer-reviewed paper. It went right across the world. It hasn't turned into the meme that I hoped it would. And actually, the people who were a bit edgy about it are the public health communities. Well, we're not sure we want to compare the drinks industry with the tobacco industry, like they're different things.
Thank you. And thank you for being short because we already have the way. Sheila, you have experience on alcohol, but not only, also advocating for women in physics. And how can you say you're having an impact? What can be the call to action? How can we prove we're giving an impact?
Well, I think firstly, if we get a chance to meet a minister, those sorts of, the graphs, clear information is really, really important, to have there. I would say, I would take a little bit of a step back is, how do you get the meeting with the minister in the first place? And, where do you need to be? So I'm all about trying to meet as many people as possible who might have contact, and maybe not with this minister, lots of other ministers. Sometimes people in the public health field feel that you can only be talking to the health minister. We need to be talking right across all departments. So just going back to our labelling example, we know that the Department of Agriculture was coming under huge pressure about the labelling issue. So you had the wine industry basically getting meetings, in fact, actually with Minister for Foreign Affairs, Minister for Agriculture. So we needed to be in there as well. So I always say, whatever the industry is doing, I'm doing too. That we have to be. But you need the contacts with the political advisors. You need the contacts in the departments, that are there. You need to be as helpful as you can possibly be. We collect a lot of data ourselves, and the Department of Health will actually quite frequently contact us for that information. And that's, you're building up, you're being a partner, you're being as helpful as possible. Another kind of a way is that sometimes we would take the heat for a decision. So just going back to MUP, we have MUP minimum unit pricing for alcohol in Ireland. When it was introduced in January 2022, there was a furore of media attention about it. And the minister didn't come out. There was no political person came out and say, this is a great policy. We're really happy about it. We're proud of it. But in fact, we came out as a very small NGO and we said, we're very proud. We're very happy. Here's the evidence. This is why we're doing it. This is why we think we're doing it. And you know what? The minister has publicly thanked us on a number of occasions for taking the heat, for doing that's there. And you know what? I was happy. It wasn't very pleasant, but I don't mind. We were telling the truth. It was easy, but there. So I think being helpful, being truthful, and I suppose trying to understand where a minister can act and where he can't or she can't, and trying to see, well, what's the bit that's sensible to be asking for at this time.
So it looks like we need some diplomatic capacity building, right? Not pleasing everyone, but still being helpful and really taking the other people into account. Freek, how do we talk to a minister when they feel they have nothing to win, when your subject, your theme is not really high up onto the agenda? How do you open the door and how you keep in the room, actually?
Getting homelessness on the agenda is actually quite easy because it's an annoying thing, but things that annoy people can be quite easily turned into political priorities. The problem with that strategy is that it often leads to the wrong policies, that entry, like narrow focus, ineffective, costly, with the objective to hide the problem rather than to solve it. That's the reality we operate in. And that's where the evidence comes in, that you have to say, well, that doesn't work, it will be costly in the end, do something else that will actually solve the problem. So that's where we use evidence. But in doing that, if you want to convince a minister, or even more important, the civil service, because ministers, they come and go in some countries more rapidly than in others. And civil servants tend to stay a bit longer. But I think it's 5 things that you have to very quickly. Pragmatism. I think we're very bad in pragmatism in NGOs, if I can be very critical. Like, of course, we want homelessness to be ended, but not immediately. You know, we can cut the objective in pieces and start with the first piece and then build on that. You know, I think we have to always realize that for a politician, it's probably an option sometimes not to do anything than to do something not good enough for the NGO sector and being criticized for it. And that is something that we want to avoid. I think we have to have a healthy dose of opportunism. I think it should not be a negative thing. The reason why homelessness is a priority, a social policy priority for the European Union at the moment is when the social rights pillar was being discussed. There was a migration crisis hitting Europe. And there was in the news, in the Belgian news, stories about asylum seekers who have a right to accommodation being accommodated in the shelter sector and homeless people being pushed out. And we use that as a hook, which is a dangerous hook, no? Because the extreme right is around the corner. We use that as a hook, but instead to say you have to get the right to shelter into the social rights pillar. And that's where it started, but it was an opportunity that we used. I think you have to persevere. That's what I learned. I'm 20 years, more than 20 years in FEANTSA. You have to constantly knock on the same nail. I don't know how you say it in English. We have been calling for an EU strategy on homelessness for the last 15 years, and it was launched 2 years ago. And they always told us, never, ever will this happen at European level. Now it's there. So persevere. And I think we have to be angry from time to time. We're so little angry in the NGO sector. I'm probably the exception there. But just to give you one example, we talk about evidence. In DG Employment and Social Affairs, the use of commercial consultancies with zero knowledge on homelessness that get massive contracts to do stupid things, and we don't say anything about it. It's a little obsession of me, but probably others as well. And I think a little bit of evilness also can help. Now, for homelessness, I understand that it's easier probably because the policies in place are so bad that progress is possible and quite quickly. You know, that's attractive for policymakers. There is a consensus on the urgency of the problem, and that's a nice entry into policy developments. None of the member states have actually solved homelessness, which is a great context because you don't run the trap to divide the countries between learners and teachers, or teachers and learners, or teachers and pupils. And that kind of dynamic is never very healthy, I find. And we as an NGO have exclusive ownership, if I can call it that way, of homelessness. So we don't have to worry about any other NGO out there. So that makes it probably quite a bit easier for us than it is, for instance, for EPHA. Can I say very quickly one more thing about the EU Commission? In the run-up to this platform that was launched by the Portuguese presidency in the Commission 2 years ago, I learned an awful lot in that 2 years, more than the 20 years before. And I have a lot of understanding and appreciation for that. But what I learned is that DG Employment, I don't want to extend to the whole Commission, but they will do the minimum possible within a given context. For many reasons, probably valid reasons. But that means that working with the European Commission as partners for a strategy is not helpful. What you have to do is work with the partners that create the context, and that will move the Commission ahead. My hope is that at some point, the Commission will understand that the context is so favorable that they have to change strategy. But I think we lost a lot of time trying to develop ambitious strategy with the civil servants inside the European Commission. And again, I understand that there is valid reasons for that, but remember that you have to change the context. And we're in a current situation, which is really bizarre, where FEANTSA is partnering up with the member states, including Hungary, Poland, etc., and the EU institutions, in a way against the European Commission to get them moving ahead. And I think that will probably change. So the mantra from the European Commission, the member states don't want, the SecGen doesn't want, etc., etc., not always true, I think.
Thank you. Very interesting. I actually came to a member of parliament recently to try to have an evaluation of the impact of the consultant, especially doing health policies in cities. And nobody wants to see that because they spend little money and everyone is happy. So I think this is things we really have to prove to, that we're not spending the money correctly. Vicky, in London, you worked on transport and air quality, but it's also come from or led to a health in all policy strategy based on evidence as public health professional. Could you give us some more example of how you do that?
Thank you. So first, just to give very, very briefly, just context, as I've said, London is the Greater London Authority is relatively new kid on the block. So it's been around since 2000, strong elected mayor and assembly that holds them to account. And the mayor provides policy direction over a number of other bodies. So the transport system, Mayor's Office, Police and Crime, Fire Brigade, and some development corporations. So we talk about the GLA group. That's what my unit has been set up to support in terms of basically public health strategy. And it's about the GLA group playing its part in full, for want of a better word. So keeping people safe. So we do have to roll up our sleeves and get involved in kind of health protection issues, incidents, severe weather. You know, I'm on call within the GLA group, etc. So it is quite a generalist public health role. I don't have a lot of space to be the subject expert in anything. Yeah, just to be clear. We've been around for a year. It's a shared service. So we've got, you know, a financial agreement with these organizations. It's a very small outfit. So these are expensive, highly skilled people. I recruit carefully, but we're tiny. It's like 9 or 10 people. Yeah. So in the scheme of things, it's small. This predates COVID. So yes, COVID helped us to make the case, and in particular, to help to draw through what the health protection role in the broadest sense is in a city, who does what. We were useful, we were helpful, and that modelled health in all policies, because every element of London's day-to-day working was kind of impacted through the pandemic. So 2 examples I'll just reference very briefly, and then I'll talk more about child obesity, building on your points earlier. So violence reduction was one area. I joined the GLA in 2018. Concerns about community safety, particularly violence impacting on young people, and particularly, I guess, a galvanization of that around knife crime. We had knife crime action plans. Would have been one example of taking a health in the policies approach by presenting back evidence, a wider sweep, not saying that something had to be public health led, but the advantages of moving to a more public health informed approach to violence reduction across violence against women and girls, how it was impacting on young people would be an example. Learning from others, so a big dose of humility. Glasgow was already doing this in Scotland, you know, enabling decision makers to meet with colleagues in Glasgow, and the mayor set up the violence reduction unit for London. Second example, maybe you know, is work we've done around housing, homelessness, rough sleeping. So moving from our cold weather, severe weather emergency protocol, which isn't a direct lever that the GLA has. The GLA is the strategic authority. But because the GLA sets out the need for an emergency protocol, temperature drops below this level, what happens? We're not just sitting there saying, oh dear, the temperature's dropped. What does London do? And that's not a matter of legislation. It's a matter of you know, development of guidelines, protocols, partnership working boards, etc. So that would be another example. The third example would be around child obesity. So to your point that you set the strategic direction, London has the highest rates of child obesity through our measurement programme. There's a huge increase between when we measure them in reception and when they leave primary school. And with an old job, an old hat on, we've done lots of work in London around that issue. We'd held a public conversation, the Great Weight debate. And so a lot of that work informed, well, what could the GLA do? What levers does the mayor have? Some of those are hard levers, some of those are softer levers. And the mayor's voice is often the sort of, you know, the cherry on the cake in terms of a political steer. Coming out of that, I guess one of the things it culminated in was something in the planning system, which was looking at levers to stop the proliferation of hot food takeaways near schools. So taking a school, 400 meters, looking at how much high fat, high salt, high sugar food is available and promoted to children around primary schools, and some work that went through the planning system. But then also looking at advertising. Now the lever is a relatively soft, well, it's a hard lever, but it could be, you know, teased out quite thin. The public transport system in London, under the governance of Transport for London, can influence what is advertised. This mayor had already taken action on body image. images and banning and restricting them. And, you know, historically, different mayors have brought in different kind of responses to that advertising policy. It's a big estate. And we went through the process to introduce restrictions to high fat, high sugar products using the national nutrient profiling model as the evidence base, but involving engagement with civil society to get that tipping point between the public wanting action, civil society organisations calling for action, work with officers around what was possible to actually get that sort of policy through. So I guess learning very briefly, we are still, I guess, as a team, as a function, by our nature, maybe quite responsive in terms of a sort of civil servant type role, thinking about manifesto commitments, thinking about what my shared service funders need. You know, what does Transport for London need? What does Police and Crime need? Thinking about our partnerships, what does the health and care system want to work with us on? And also think about national policy. So we have the national major condition strategy. How are we working with government? But I guess the rub is, how do we start to be more and more granular about where the big public health wins are? So where are the big risks? Where can we operate at scale to get even bigger impact on public health?
Thank you so much. So because we have 3 minutes left, 1 minute each. I think we have two approaches. Like, one is really the flagship of public health and like some kind of imperialism, all for health. And another, which is like the subversivity, like how can you be more subversive and change the political decision? So let's imagine that we all together, all our organization, imagine the thousands of members could do one thing and go with you and change one thing and go advocate for one thing to one minister. Who would that be? And what would be the theme?
It wouldn't be to the minister. It would be to the responsible civil servant. Ministers come and go with blinding speed. And unless you've got the key civil servant on your side, you haven't got a hope. And it has to be the right civil servant, okay? If you want to change price, you've got to be speaking to the Treasury. The Department of Health are it's a waste of time. They speak to the Treasury, but all they do is ask for more money. What you want to say to the Treasury is, look, taxes increase your revenue and decrease your costs. That's the sort of argument they understand.
In a similar sort of vein, I'd be saying we all need to be talking about commercial determinants of health, but we need to put it into language that's very understandable. So in my case, or what we think from an alcohol point of view, is to really point to the supernormal profits of the alcohol industry. Diageo made 3.5 billion sterling last year. Funny enough, the cost of alcohol harm in Ireland, which includes, remember, their most popular beer, is about the same amount. And I think, you know, making those very direct links between the costs and the polluter and pointing to this is the environment that we're working in, and strip away our attachment to this product as somehow being synonymous with our national identity allows, I think, pointing to those profits allows us to do that a little bit more.
I think there's a lot of choice of things, but I think what my message would probably be to the health community in general. And it's that health, it sounds stupid, but it's like, I'll explain, but the health inequalities also concern the most marginalized parts of the population: homeless, undocumented migrants, sex workers, marginal sex workers, etc. And it sounds evident, but it's not at all evident. If there is no explicit mention or explicit targeting of these groups, they tend to be overlooked systematically. At the moment, we could say, if you look at the EU for Health program, health inequalities is mentioned, is sort of mainstreamed in the program. But if you look at the actions that have been taken, they are systematically overlooked. Health inequality, the Cancer Inequalities Register, it's about inequalities, and they just don't measure, like homeless people are actually excluded from that register. Even if they're more vulnerable to cancer, certain cancers, they're less likely to be diagnosed early, they're more likely to die earlier, etc., but they're out, and there is no action being taken to integrate them. So my call would be, if you're serious about health inequalities, don't forget these very marginal groups.
So I'd be saying I'm not a health imperialist, so I would definitely not be saying it's health above everything else. If we're pursuing social, economic, environmental aims, which the Greater London Authority does and others, health needs to be considered in the fullest sense in each of those kind of aims. We need to consider equity alongside that, yeah, as a fourth aim. And I've now gone complete blank. That's not very helpful, is it?
So who do we go to see with you? Who are we going to see with you? Who are we supporting you to
So I'm
change?
still learning that. So, and that comes back to the political system in which you're working. And I've worked in many different guises in the local health service, in local government, etc. So that you have to understand that political system that you're operating in, where power sits. Sometimes it'll be hard power. We've talked a lot about legislation. There are other levers as well as I'm not dismissing legislation. There are other levers. And to affect that change, you need to understand that. It's just come back to me. My final point would be, to Michael Marmot's point earlier, health is not, in the UK context, just the NHS. So when we're advocating for health to be included in environmental, economic and social outcomes, we are not just talking about the role that the health and care system plays.
Thank you very much. A big round of applause. I hope you have food for thought.